Okay, let's get started. So, welcome again. My name is Eliana Monteforte. I'm the Director for Special Projects at Global Health Council, and you have joined our 101 webinar on non-communicable diseases. I'm going to go ahead and start us off with a few housekeeping as well as our agenda. So first, we're going to do a few welcome and introductions, particularly our first set of speakers. I'm going to give you a bit of an overview on Global Health Council if you're not familiar with us. And within the Global Health Council, we have a non-communicable disease working group. So I'll give you a little bit of information on our working group, which has actually come together to put this presentation and this webinar for you today. Then we're going to go ahead and talk about the NCD global landscape. And we'll then move on to the second portion of our webinar, which is a fireside chat with some NCD patient advocates. And then we'll have our closing. We will try our very best to allow for questions at the end of our fireside chat. In the meantime, we will be answering questions in the chat box. So as our presentations begin and move along, if you have any questions at any point, please type them in the chat and we will answer them as we go. And then after we hear from our patient advocates, if you have any other questions and we have a few minutes, we would love for you to either type them in the chat or you can raise your hand and we'll allow you to come off mute so that you can ask those questions. So here's some housekeeping. You know the chat function. Hopefully this is what it looks like. You can unmute yourself using the unmute button. And of course, you can share reactions if you want to give any speakers a round of applause or a thumbs up. Okay, so let's start with some introductions. So as I said, I'm the Director for Special Projects at Global Health Council, and I have two other speakers with me today. Katie Winkworth-Preschner, who is one of the co-chairs of our NCD working group and from the National Comprehensive Cancer Network. And then we also have Kate Doherty, who is our second co-chair for the Non-Communicable Disease Working Group here at Global Health Council from Global Arch. So a little bit about Global Health Council. So GHC is a leading member organization devoted to advancing global health priorities by uniting advocates and implementers, policymakers, and other stakeholders. So we're a membership organization, and our membership is made up of various different types of organizations, from civil society organizations to multilaterals, to international implementing organizations, NGOs. We also have academia, even people from the private sector. And we truly believe in the collective voice and in the power of the collective voice and bringing advocates together to align and coordinate advocacy to be more powerful in sending our message and making a health impact in the world. So one of the ways that we do that is we have various working groups at Global Health Council, and each working group focuses on a specific area. And our working groups are made up of our GHC members, and they come together to do exactly that, to collaborate, to align, to share knowledge, to meet with different leaders and talk to them and find out ways that we can have better impact in our advocacy. One of our working groups focuses on non-communicable diseases. And again, this is a platform where organizations that work in the NCD space come together to align and coordinate advocacy. And our working group in particular has three important goals that they are focusing on. First, it's educating and building awareness around NCDs among the US government, but also among other governments and even other advocates. We found that a lot of our partner advocates don't quite understand NCDs and particularly what disease areas fall under NCDs, which is why we are doing this webinar, and a lot of our other advocacy is going to revolve around building that knowledge and awareness around NCDs. So not only with governments, but with our partners and other advocates as well. Also building awareness around the investment case for NCDs among multilateral agencies, really important for multilateral agencies, but even other key stakeholders, especially governments, to understand why it's so important to invest in NCDs and how many lives you can save and money you can save by doing that. And then third, align the larger NCD community around engagement with the 2025 high-level meeting on NCDs. So the United Nations General Assembly happens every year, and as part of those, they often have health-related high-level meetings. And in 2025, there will be a high-level meeting on NCDs. And so this working group is going to be focusing on the advocacy in the lead up to that high-level meeting, and also during and even after the high-level meeting. So that's one of our key priorities, and you will be hearing more from us after this webinar on activities around those. So as I said, the GHC NCD working group is only open to Global Health Council members in good standing. We certainly do partner with organizations outside of the GHC membership in implementing some of our advocacy activities. But the monthly and day-to-day activities that we do under our working group really falls under our GHC membership. So now I'm going to hand it over to Katie, who's going to take us through the NCD global landscape. So Katie, over to you.
Thank you so much, Eliana. It's really a pleasure to be here with everyone. And as mentioned, I'm Katie Winkworth-Prejnar. I work at the National Comprehensive Cancer Network, NCCN, and I also co-chair the NCD working group. So today I'm going to briefly go over what NCDs are, their global burden, and the ways multilateral agencies and other groups are really working hard to address these diverse conditions. So I want to first start with just the simple question: what are NCDs? So non-communicable diseases, also known as chronic diseases, have some common features that relate to both health status and health-related treatment. So the first is that they're not transmitted person to person. So even if an infectious agent is involved in the etiology or pathogenesis of the disease, they are not transmitted like an infectious disease. The next is that several NCDs have some shared risk factors. Some of the most common risk factors include tobacco use, physical activity, harmful use of alcohol, diet, and air pollution. NCDs will often coexist with each other, and typically patients have more than one chronic disease at the same time. And you'll hear from the patient advocates later about their experience with dealing with and living with more than one chronic disease. There's usually a long latency between typical exposure and ultimate disease progression. NCDs are also chronic and long-lasting, meaning treatment must continue over a very long period of time. And this requires specialized healthcare systems to manage NCDs, which are often quite different than the system set up for infectious disease areas. These are also a cluster of conditions that not only cause premature mortality, but also impair quality of life. So symptoms and risk factors can coexist and interact with each other, contributing to worse symptom severity, illness, and the possibility of premature death. It's also important to note that in addition to health-related consequences, chronic diseases also have substantial non-health consequences. So for instance, they can affect economies. So a person's ability to work, their economic situation in terms of paying for treatment, and other social factors related to quality of life. The types of NCDs that are most discussed are cardiovascular disease, such as heart attacks and stroke, cancers, chronic respiratory diseases, and diabetes. Next slide. But it's not just these 4 disease areas. And it's important to remember that there are a significant number of diseases that fall under the NCD umbrella. And this is not even a full list. This is just the most common occurring NCDs. And we really want to make sure that all these groups are included and active in advocacy discussions as we move forward as a collective voice. Next slide. Now I want to shift to the magnitude and burden of NCDs. So the chart on the left shows the increase in number of deaths from NCDs over the last 20 years, with current estimates saying that NCD-related deaths worldwide are over 4 million, and this represents about 65% of all deaths worldwide. A quarter still represent infectious diseases, and about 10% are due to injuries, both intentional or unintentional. If we want to look beyond mortality, the chart on the right reflects both the risk of premature mortality, but also, and really importantly, quality of life. And this is a measure called disability adjusted life years, or DALYs, which simply means years of your life lived with a disability. And again, we see the significant rise in disease burden of NCDs, which are now surpassing infectious diseases. Next slide. Just some more statistics on the global NCD disease burden. As mentioned, NCDs account for over 40 million deaths worldwide, and this number continues to grow significantly. 86% of those deaths occurred in low and middle income countries. And this is in a landscape that these countries are still dealing with the unfinished agenda of infectious diseases, coupled with the rise of NCDs. 40% of these deaths could have been prevented, and poor, vulnerable, and marginalized populations are often most affected by these conditions. Next slide. Despite the increase in mortality and disability from NCDs, the global health funding mechanisms have really not kept pace. So the NCD Alliance puts out some great advocacy tools and does wonderful work around advocacy for NCDs. And this chart that they published shows that in 2015, even though 67% of deaths in LMICs were due to NCDs, only 1% of total health funding, and that included government, charities, other international organizations, was directed to addressing NCDs and LMICs. This is part of a larger landscape that has included decades of underfunding and inattention to NCDs and mental health due to developmental assistance often not being based on the needs. This also represents fragmented and uncoordinated responses caused by limited sources throughout the global health environment. And lastly, dominance of the global north decision-making, perpetuating a model of dependence for LMICs. Next slide. As a community, we are encouraged that NCDs have increasingly been part of the larger global health and development agenda. So Eliana mentioned this in the beginning, but there has been an increase of health-related special sessions and high-level meetings held during or alongside the United Nations General Assembly, UNGA, including several focused on non-communicable diseases. So the first high-level meeting on NCDs was held in 2011. And since then, there has been the adoption of an NCD-related Sustainable Developmental Goal, SDG. This is Target 3.4. There's also been the development of the NCD Global Monitoring Framework and other areas of focus on unmet needs of NCDs like oral health and NCDs humanitarian crises. So despite this attention and coupled with the setbacks of COVID, there are still significant challenges for the necessary budget allocations to NCDs and the domestic NCD policy implementation on the ground. So next year, as Eliana mentioned, it's really critical during the UN high-level meeting on NCDs that we come together as a collective voice and make sure that NCDs are focused on and budget is allocated, and really patients get access to the care that they need. So with that, let me hand it over to Kate to introduce our amazing panel of NCD advocates, to hear from them about their experience and their work, really making sure that NCDs are on the agenda. So thank you so much.
Thank you, Katie, and thank you, Eliana and the Global Health Council. My name is Kate Darty-Schmeck. I am the Executive Director of Global ARCH, the Global Alliance for Rheumatic and Congenital Hearts, and also the co-chair of the NCD Roundtable for the Global Health Council. It's an honor today to have the opportunity to speak to 3 advocates from around the world who are living with NCDs. We'll have the chance to not only hear about their experiences of living with a chronic condition, but also guidance on how we, as the advocacy community, can help better support and collaborate with patients to make an impact on the issues that matter most to them. So to get started, I'd love to have the advocates introduce themselves and tell us a little bit more about their experience. So Kathy, I'll begin with you.
Okay, thank you. Thank you, Kate. I'm Catherine Hammett, and I have Sjogren's disease, which is the second most common autoimmune rheumatic disease. It's second to rheumatoid arthritis in number. I was 14 when a physician first suspected a rheumatic disease, but it wasn't until 17 years later that I was finally diagnosed. It can affect any body organ or system. It always targets the moisture-producing glands, so dry mouth and dry eye are top symptoms along with fatigue. And I don't know if you know this, but you have to lose 50% of your saliva before a person realizes that they're dry. And so in the meantime, we get rampant cavities, teeth that chip and break, tooth loss. And when we lose our teeth, dentures won't work. We get oral infections, and these can lead to systemic infections. We're also susceptible to blood cancers such as non-Hodgkin's lymphoma. And for mothers who wish to get pregnant, we have a high risk of fetal heart block. So I have been coping with this for a long time.
Thank you, Kathy. Hagla, I'll turn to you to introduce yourself.
Yes, hello, and thank you for having me. My name is Tekla Björk. I'm 24 years old and I'm from Iceland. I'm currently studying social work in the University of Iceland, and I have been doing some volunteer work for Nestin, which is a sponsoring organization for children with heart defects in Iceland. Myself, I was born with a heart defect called truncus arteriosus. It is a rare heart defect where a single common blood vessel grows from the heart instead of the 2 usual ones. I have had to undergo 3 surgeries. And the first time I was flown, I was only 1 day old. And when we arrived to Boston, they found out that I had truncus arteriosus, so I was diagnosed with another defect here in Iceland and when we got to Boston. The second time I was 11, 12 years old, and the third time I was 14 years old. So yeah, this is very hard to live with, but yeah. The third time I went, it was an emergency flight. I had been sick for over a month and I was in and out of hospital, and no one could find out what was wrong. My whole body was aching and I was always freezing or too cold, like too hot. And then the doctors diagnosed me with pneumonia and I was given antibiotics. I got a little bit better and I went to school, but after taking all the antibiotics, I got even worse and kept losing and regaining consciousness, and my heart was racing And my mother called my pediatric cardiologist, who told us to go back to the hospital, and he finally found out what was wrong. I had gotten an infection in my heart since my immune system is not that good because of my heart defect. And that meant I had to fly out the next morning to Boston to have an open heart surgery. And yeah, today I just go through life one day at a time, go for a few checkups yearly. And yeah, this is a chronic disease that is not just going to go away because, yeah, then I have to go to another surgeries throughout my life, and it can be very terrifying.
Thank you, Hekla. And Moses, I'll turn to you to introduce yourself as well, please.
Right. Hi, everyone. My name is Moses Echodu, and I'm from Uganda. I'm a childhood cancer survivor. I've been free of, I don't know if the word is free, but I've been surviving for the last 23 years. I first was diagnosed with cancer when I was 8 years of age. That was back in 1998. And I was diagnosed with Burkitt's lymphoma, which is the second commonest type of cancer in children in Uganda after leukemia. So after campus, I was immediately ambushed by Dr. Jackson Orem, who is the executive director at Uganda Cancer Institute. And he said, we could use a survivor like you in the work that we do, in education and awareness programs. So along the way, I, really got invested in the work that they do. Around 2018, I left the foundation that I was working, that was Uganda Child Cancer Foundation, to try and pursue my career, that is information technology, because that's what I'd studied at university. But then when COVID came, most of the people who were running the foundation at the time left to try and, find their own footing, so to say, because COVID had taken the organization by storm, and there was no finances, so people needed money. So Dr. Rem again calls me and says, Moses, if you don't come, the organization is going to close. So from then on, up until now, I've been working with the foundation, but also doing my advocacy work for childhood cancers. And as I was telling Kate and yesterday and Katie, that in last year, I decided to take on a new challenge to mentor an organization that is supporting sickle cell warriors. So yeah, that's who I am.
Thank you, Moses. I am so thrilled to talk to each of you. I've had the opportunity to get to know more about each of our advocates over the last few days, about living with an NCD and a chronic condition, as well as the incredible work that they do in their daily lives in each of their respective careers and as a student. So I'm very happy to get the chance to talk to you today. So to move to some of the questions we have, the first question is, what are the biggest challenges you face living with a chronic condition and NCD? So Hekla, I'll start with you if you don't mind responding.
Yeah, it's okay. Yeah, living with this defect has had a big impact on my life, my family, and our close ones. One of the many challenges me and my family have faced are that the necessary surgery I need is not performed here in Iceland. So me and my parents have had to stop everything and leave our everyday life behind to fly all the way to Boston so I can undergo surgery. I have now three younger siblings, so it's hard on them and my parents that they have to be left behind when we have to go to a whole other country. And this has affected us both financially and emotionally. However, my biggest challenge is how all this has affected me mentally. Mentally, I'm sorry, I'm from Iceland, so this is not my first language, but yeah, has affected my mental health. I have experienced so much fear, fear that no one my age should ever have to experience. I faced a life or death situation when I was only 14 years old. We have had to fight for our rights to get the health care that I need here in Iceland. It has even gotten to a point where doctors didn't listen to me or my mom, so my dad had to apply harshness against the system. We have had to seek outside the hospital just so we could take care of our mental health. I've been knocked down many times by my peers and my own health issues to a point where I almost gave up. But yeah, uh, the system has failed me and my family more than once, which has led to that I have lost my trust in the healthcare system. I've had many visits to the hospital throughout the years that can be tiring and nerve-wracking on me and my whole family. All this fear and traumatic experience has led to that I now have been diagnosed with post-traumatic stress disorder. I want to have a normal life like everybody else, but I have to adjust my lifestyle to others since society doesn't know how to adjust to my situation, and that can be a lot of work. Because of my heart defect, I can't do everything like everybody else, and tasks that are normal to others can be very difficult for me. But this is my life, and I do what I can do with or without help just so I can live as normal a life as possible.
Thank you, Ekla. Thank you for sharing your experience. I know it's not always easy, so thank you so much. Moses, what are the biggest challenges you face?
Yeah, so it's you know, when I was doing a training with the NCD Poverty Network, one of the things I learned along the way is that oftentimes you find as people living with non-communicable diseases, our experiences in a way they meet, there's a way they are similar. Mine was really after my 2 years of treatment. For about 10 years, I had constant migraines, and I could not explain how and where they were coming from. I would drink enough water, I would eat food on time, I would sleep on time. I think at least that's the beauty I had, that after my treatment, I could sleep, because during the time of my treatment, I basically had no sleep. But after treatment, I had sleep. But the whole idea of migraines was foreign to me. But also I faced the challenge of I could not tell my story for fear of they're going to judge me. They're going to see me as not enough or not good enough. So I remember even while at school, because I was in boarding school, it was my teachers who knew my story. It was my teachers who knew what my experience was. So whenever I would fall sick, even if it was just malaria, quickly they send me back home, because they didn't want to find themselves in a situation that they could not manage. And that for me was also another challenge, that I could not just fall sick as a normal person. Any slight sight of illness was seen as perhaps the cancer is back, perhaps the cancer is back. And so there was always that glaring worry. But along the way, as well as I continued to grow and I continued to interact with different cancer survivors, different cancer patients, I quickly learned that there was never really a time for comfort, because anytime as a person who has gone through the journey of cancer, there's always that possibility of the cancer coming back and lurking around. So you find that now I have to carry out tests almost every single, 7 months, 1 year. There are times when because I work around the Uganda Cancer Institute, our offices are just within the Cancer Institute. So I find there are sometimes when I'm in the lab and the lab guys are, what are you checking for? And I tell them, I'm just being cautious. So I get the results, take to the doctor, he breaks down and says, there's nothing, we're good, go back to work. And I said, no, but I'm feeling, no, you're just stressed, get some more rest. So there's always that bit of a challenge. But also, I didn't know that one of the side effects could actually be um, related to reproductive health, because I faced some bit of those challenges. And every time I would try to engage with my partner, there was always that challenge. And so I didn't know until I had a conversation with someone who had done some bit of research into some of the side effects that survivors express along the journey. So I would say those are some of the challenges. I cannot talk about difficulty in accessing services or in accessing care, because that difficulty is something that I experienced when I was getting diagnosed. Because at the time of my diagnosis, or at the time when I had the first symptoms, I was literally staying, I'd say, 500, 600 kilometers away from where the treatment area was. So when I traveled all the 600 kilometers, there was family in the city, that is Kampala, because a lot of I would say the top or specialized services are within the capital city of Uganda. So you find so many different patients have to travel all these different distances to be able to actually get the specialized care. And so that of course now that is something that has now blessed my advocacy journey. That why do we have only one specialized area for treating a disease that is now as big as it is now, that is now as common as it is now? Why do people have to spend all their lives savings or lives, earnings or whatever they have gained as wealth into treating just one person? And so that for me, that was the experience that I had in terms of access to care. Now I can access it because I literally work in the center of the Uganda Cancer Institute. So anything happens, I know this is the doctor to see, this is the nurse to see, and this is the lab technician I need to visit, things like that. I walk into any office and they say, "Oh, Moses, what's up? Are you okay?" And so it's easier now, but the question still lingers for the over 1,000 other people that are out there. So in terms of my personal challenges, in terms of my personal experiences, I would say those are the first ones that I mentioned. Yeah.
That's wonderful. Thank you, Moses, for sharing that. And, I think with both congenital heart disease and cancer, you both face, or any NCD, it's you have good days, you have bad days, but always worrying, is it back? Or am I having some type of episode or some type of reaction? Am I going to have to fly out of the country again to receive care? Am I going to have to be back and not sleeping because of migraines, and the impact that has on your daily life and the economic side as well? Thank you for sharing that. And Kathy, I know you not only are a person living with an NCD, but also your incredible work at the Sjogren's Foundation. In your work and as a person living with this condition, what are the biggest challenges you face and have from your work as well?
Thanks, Kate. All Sjogren's patients can be a little bit different. We might have some of our symptoms might be more burdensome or harder than others, but we do share a difficulty having clinicians recognize that we have this disease and getting a diagnosis. And then even in the United States, we have trouble getting access to good care and to clinicians who really understand and know our disease. On a personal level, as I mentioned, it was first suspected in me when I was 14. So I've struggled with symptoms for a long time. And because I didn't have a diagnosis, I was just told, well, you just have to get tougher. You're just not tough enough. You're reacting to the sun. You just have to avoid the sun. You can't breathe. You're in pain. Well, again, just toughen up. And so it was very hard to have anyone take me seriously. So I learned just not to complain. And so you end up becoming isolated and you struggle alone a lot. And then when my daughter was born, I had a fever and severe fatigue for 2 years straight. So I was in the hospital. I could not lift her out of the bassinet. I couldn't put her back in the bassinet. And the nurses just would tell me, everybody's tired after having a baby. You just have to start moving and get over it. So that makes it even harder when you don't have that recognition and of what you're going through, and that what you're going through is real. So this disease ended up affecting the kind of mother I had always envisioned that I would be. There were repercussions for my whole family. I had to quit my job. My husband had to step up to the plate more. You also deal with family understanding the disease. I finally got a diagnosis 2 years after my daughter was born. I also had a tentative diagnosis 3 times of the non-Hodgkin's lymphoma that often accompanies Sjogren's, but showing the lack of knowledge, sometimes the pathology can look similar, and it's sometimes hard to tell what is benign lymphocytic infiltration and what is malignant. This didn't, once I got the diagnosis, it didn't mean that anyone else understood what I was going through. And that was one of the hardest things. Then when I did get the diagnosis, I learned I was highly susceptible to having a baby with heart block. I did have a second child, but I worried through the entire pregnancy that my baby would die in utero or die shortly after birth. So instead of having the joy of having a pregnancy and anticipating a child and an addition to our family, I was just really worried the whole time. I had a career that I absolutely loved. I was a television news producer and writer in Washington. I had to quit my job because of my severe fatigue. And then with one small child and then two small children, I had to focus on trying to get back on my feet and learn about my disease and find ways to live with it. When you take dry mouth alone, I can't talk for long periods or eat without sipping constantly on liquids, and I choke on food. So this makes it really difficult to perform work that involves a lot of talking. It makes it hard to be social. I can't go out to restaurants. I can't go out and eat with other people. It's really embarrassing. And you look at the cost of having a chronic health condition, it's awful. Dental repairs alone are absolutely exorbitant. And then you look at having to go to so many specialists since any body organ or system can be affected in Sjogren's. I feel like I have a full-time job just trying to take care of myself and then trying to go to doctors and get the basic help that I need. And you add to that you've got the tremendous fatigue and having to do all of this and musculoskeletal pain, and that further exhausts you and reduces the quality of life. Dry mouth and dry eyes and fatigue are the top three symptoms in Sjogren's. So with my eyes hurt and they burn. My vision is often blurry. That makes it hard to work on the computer or read materials that I need to read. The fatigue just makes it really hard to participate in social activities, do things I need to do for my family. And I have ended up working for the Sjogren's Foundation, and I'm grateful for that. But that also takes a lot of time and energy. But I just feel so passionately about getting help for patients who are so oftentimes misdiagnosed, underdiagnosed, misunderstood, and are dealing with the burden of all of these myriad symptoms and not being taken seriously, and people not understanding what we live with day to day.
Kathy, I think the way you said that of the standout, you many comments, but especially it's a full-time job. It's a full-time job in addition to working, in addition to your personal life and being a mom or being a sister or what brother, Moses, and or a son or daughter. It's a full-time job in addition to just living everyday life. And it is incredible also, no matter what type of NCD you have, the similarities we've heard from each of you, no matter where you're located or the type of NCD, whether it's from, being open to talk about what you're going through in the fear of the stigma around it. Can you trust who you're telling? And the late diagnosis from Hecla, you were diagnosed at 1 day old, and Kathy later on, and it took 17 years for you to be diagnosed. And, Moses, you were able to be, but I know there was a lot of fear around that and the reoccurrence. So thank you for sharing that. And also about the having children, the reproductive side of it too. I know with each condition, there's fear and there's concerns over each one, and that's nerve-wracking. And thank you for sharing that and how that impacts your journey of becoming a parent if you choose to be. So we'll turn to the final question, and then Thank you. What are the most important issues that advocates and other stakeholders should address in their work? So, Moses, I'll start with you.
Yeah. So advocacy is really, I'd say first, it's a really interesting journey, especially for people living with NCDs. Why? Because oftentimes 70% of advocacy is out of emotion, you know, and it comes from a point of I want better for someone. I want better for the next person, and things like that, and rightfully so, because we wouldn't want. I personally didn't want the next child to have to go through you know over 1 year and a half of treatment that I went through. You know, I didn't want to see another child having to struggle with aspects of nutrition, and that is why I do the advocacy that I do today. And for me, it's important because as of last year, we realized for the first time the entire year, every single child who was receiving treatment at the Uganda Cancer Institute was getting breakfast, and that was very important because that's a starting meal for anybody, and if you're going to get chemo, that's a very, very important meal. So for me, the important thing is we need to know when we have to apply our story. We need to know when we have to apply our emotions. But importantly, we also have to know when does our story intersect with the medical line of things? When do we not try as much as possible not to make our needs greater than the requirements of the medical requirements, because the two move together. Unfortunately or fortunately, the two move together. So you find that you always have to find yourself in a situation where um, you're supposed to be encouraging patients to take the medication, but also you have to be able to put yourself in a situation whereby you understand that the needs of the patients are also very important. And one of the things that we have done, or that I've done, is try as much as possible to get myself involved in some of the research projects that have been happening, because it's at the research element that you also find that you can make an impact, you can make a contribution. And I'm very happy that right now in the cancer world, one of the things that I've seen that has become very prominent is that in order for a project to be accepted, there has to be an aspect that involves a patient. In terms of, are you involving the survivor? Are you involving a patient? Because you might come and you want to do your very scientific research, but the question is, what is happening in the psychosocial element of this patient? How is your project feeding into the psychosocial aspects of the patient? Because the psychosocial aspects of a patient are the ones that will make the science work. That's the part that we have been talking to our doctors whenever they say, why do they need patients? And we tell them, unfortunately, the psychosocial aspects of the patient's journey are the ones that make the treatment successful. Because if a patient does not have transport to be able to come to the hospital, they're going to abandon that treatment. If they do not have finances to eat food, they're going to end up abandoning that treatment. If they do not have, uh, required finances to be able to purchase, say, supportive medicines, then you're going to find yourself again with a patient that is going to abandon this treatment. But also, as patients who are able to tell you as doctors that, listen, some of the costs that you're putting up are good costs, yes, but they are limiting costs. So they're limiting access to care. They're limiting access to opportunity for you to save another life. And we've seen a very progressive change here in Uganda in terms of how patients are handled, in terms of, because one of the things that I used to tell them is that when a patient comes to the Uganda Cancer Institute, the question is, where do I start from? And so there was a need to introduce patient navigators. And the patient navigators were then brought into the system. And now they help patients. Now patients will come, they'll ask, I'm my first time here, where do I go? And some even as far as a security guard is able to say, go to the other direction, and you'll be able to actually, start the journey for your treatment. And so that has been something that has been helpful. So the question is that, how do you, as an advocate, make sure that you look at the psychosocial aspects of, your fellow patients, and how can you advocate for them to have aspects that are improved? And perhaps also the other thing is get very involved in the policy developments, because it's at policy developments that a lot of things that affect patients are brought forth. For instance, Uganda were developing the National Cancer Control Plan in 2020, and when I went into the conversation, we quickly realized that there was no pillar that was focusing on the pediatrics oncology. And so we asked, why don't we have a pillar that focuses on pediatric oncology? Because children experience treatment differently. They experience the journey differently. The requirements for treating a child are extremely different. And so I ended up making the journey of designing the National Cancer Control Plan longer than it should have been, but everyone appreciated that it was actually very important. So whenever there is an opportunity for development of national policies or policies that affect your area, there should be interest to put your foot into it and make sure that you're heard, you're listened to, because at the end of the day, you walk the journey, and you know what other patients are going through in order to get the care that they deserve. And so, but as I conclude, because we could talk all day about what important issues, but for me, the other issue is, as much as you're getting involved in policy development, be very, very vocal about health financing. So you find that most of the countries worldwide, the biggest budget will always go to security. And most of these security issues are self-designed by these countries. If no one was trying to get into the other person's space, we'd all live happily ever after. But again, it can't happen. So, so there's always a big budget for security. Mm-hmm. So you find that it's important that we have ourselves heard concerning financing for health. And why do I say this? Because you find so many different sectors of the government's budget are always going to focus on, security, education, and things like that. And then when they come to health, you find that the diseases that are going to have the biggest budgets are going to be the diseases that are very common. For example, here in Uganda and sub-Saharan Africa, you find there's a big budgets that are put for malaria. There's big budgets that are put for HIV/AIDS, and HIV/AIDS right now, I can confidently say they have a lot. Everyone literally knows I should get myself screened every 3 or 6 months. I should make sure that I wear protective gear and things like that. But how is someone with rheumatic heart disease going to wear protective gear? That's always going to be the question. So why shouldn't we now focus a lot of our finances towards, the what you call the diseases that are very difficult to manage? So you talk about heart-related diseases, you talk about diabetes, you talk about sickle cell, you talk about cancer. These are very, one, expensive diseases. Number two, they are also very difficult in terms of, they're very difficult to the patients and to the person. So as advocates, we have got to be very vocal and ask that government people, as they are budgeting, a big chunk of budgets actually goes to non-communicable diseases. As I said, I could talk all day, but let me stop there.
Thanks, Moses. I agree. We could talk all day about this because the importance of it and hearing from you. Thank you so much for sharing that. I think, the importance of financing access to care, whether it's the initial diagnosis and correct diagnosis and access to affordable quality care, and to the specialists that are needed for each condition, for not only the physical health, but also the emotional, the psychosocial, the mental health of patients, and not only at the initial treatment, but also lifelong. Any condition of these conditions are lifelong, and making sure that it's not one and done, but that patients are receiving lifelong care and helping to strengthen our healthcare systems so that they can help respond to this as well. Kathy, I'll turn to you. What are the most important issues you would like to share?
First and foremost is that we need international collaboration. Our world is small today. We're all human. When we have a disease, it's no different in Iceland or Nigeria or the United States. And we all need to join hand in hand to make sure we find answers and that we get the access to care and the changes we need. Awareness and education is absolutely critical. It's critical for diagnosis. It's also critical because we need a diagnosis to show the world that our symptoms are real. And even when we get a diagnosis, we need clinicians to be aware and well educated about our diseases so that we aren't continually misunderstood. I know at one point the American College of Rheumatology, for example, had on their website that Sjogren's was a nuisance disease. We were able to get that changed, but it is not just a nuisance disease. We need regulatory agencies and companies to understand that in Sjogren's we have no approved therapies and we desperately need those. I'm sure that's true for many diseases. And I love what Moses said about getting involved and how important it is for patients to be part of clinical trials and other studies. In Sjogren's specifically, and again, I'm sure this is true across the board for many non-communicable diseases, is that Sjogren's is serious and it's systemic, and we just need knowledgeable providers out there, and we need that access to care.
Thank you, Kathy. And Hekla, I'll turn to you.
Yes. In my case, I would like you to keep in mind, people, that I'm my parents' firstborn. So imagine the shock when their daughter getting to the world after waiting for her for 9 months, and she's just taken away from them to get tests, everything, and then has to be flown out to a whole other country, not knowing if I would even survive. I know there are others that have gone through the same, that not knowing their child has a heart defect until they were born. But yeah, for me and my family, the biggest issues we have to deal with is getting back on track after we go back home from the hospital. In my experience, I feel like I'm just uh I'm just a task on a to-do list that needs to be checked off after I get home from the hospital. That after the surgery and I'm getting better, we're just sent off all alone to take care of everything and get back to our normal day lives. Me and my family, however, are very lucky for all the support we have from our close ones, but they can only help to a limited extent. The lack of support from the system and lack of understanding in the community we live in is something that needs to change. We need to feel safe. And because the truth is, the process isn't over for us, even though the surgery is over. We have to learn to adjust ourselves all over again to society and get back to the normal everyday life. I have to learn all over again to do everyday tasks and build up my endurance and immune system. And all that adjustment work can be very hard after traumatic experience that the system we live within left us all alone, all on our own to rehabilitate my physical health and our mental health. After my last surgery, my parents even sought out to the hospital for any support, but they were just directed out the door. So yeah, when people's mental health isn't taken care of, they may have a hard time to function physically and socially. Bad mental health is an important issue that needs to be worked on, especially when it comes to living the NCDs. Don't get me wrong, I don't want people to treat me any different or feel sorry for me. I just want people to show understanding and the government to support us when we need it the most. in addition to that, the system needs to change. Now that I'm over 18 years old, I get lost in the system. I have to fight more with the system and even use my story of how I got this infection and nearly died just so I could get the care that I need. It has even come to a point that I still have to seek help from my father to fight the system for me. And I know there's a lot of pressure on the system, but we need more long-term service.
Thank you, Hecla. Thank you to each of you. I would like to just ask one additional question, and I'll have just one of you respond if that's okay. Is something that has stood out is the concern over mental health, which appropriately so, as the impact it has on your physical health and your daily life, your social well-being, your ability to live every day. What can advocates and other stakeholders do to better address a mental health response in their daily work? So, Kathy, if you don't mind responding to that, just very quickly. I know we're limited on time, but I would love to hear your opinion on it.
Sure. I think to understand that the mental burden is as severe as the physical burden. And so mental health is every bit as important as getting the management and treatment for our diseases. It's the mental aspects that really pull us down in our daily life and also deplete our confidence in our ability to cope with our diseases.
Thank you. Thank you for sharing that. And thank you to all of our advocates, no matter where you're from, Iceland, Uganda, the US, to be able to share how living with an NCD impacts your daily life and also your overall, day. Thank you so much for sharing that. And thank you to the Global Health Council, Katie and Eliana. Eliana, I'll turn it back to you. Thank you so much.
This has been so eye-opening. So I also want to thank our patient advocates for giving us those personal experiences, because it really helps people understand what living with NCDs truly are, and also how challenging life can be living with NCDs, and what we can do as advocates to help address some of those challenges. There was a lot of discussion in the chat, which was really great. One of the things that stood out was how many different diseases actually are in NCDs. Everybody often talks about the 4x4. There's a lot of chat in that. There's many more NCDs than just the 4x4. And as Katie emphasized in the beginning of her presentation, it's not just those four. It includes mental health, which is something that we've discussed a lot. It also includes, David Bryden had mentioned long COVID and how long COVID is now an important part of NCDs. Even in the chat, we talked about how a lot of infectious diseases can actually create and cause chronic diseases, and so in turn impacts NCDs. So really important to hear about that. We heard a lot about how primary healthcare can help address NCDs, how training health and care workers and community health workers to be able to prevent, to screen for these NCDs. And even there are some treatments that can even be done at the primary healthcare level that trained care workers could possibly administer. And so the discussion around PHC and health workers also came up quite a bit. So I'm really thankful for everybody that joined us today and that participated in the chat. We hope to have more of these webinars as part of the Global Health Council NCD working group. So please look out for more invitations. This recording, as well as the PowerPoint presentation, will be shared with everybody who has registered, as well as all of our networks and our patient advocate networks as well. So please look out for those. And we also encourage you all to share these materials and this recording and our wonderful patient advocates accounts far and wide to further educate people around NCDs. So with that, I will say thank you to our co-chairs as well, Kate and Katie, for the wonderful chairing that you did today. And I will send everyone off. Thank you so much. Bye, everyone.
Thank you. Bye.
Thank you.
Bye-bye.